Okay, so I have the exciting chance to move from one microphone to the other, but then I get to go off and find myself some additional caffeine. So up next, we have brain imaging guidance, targeting, and monitoring. And this is going to be moderated by Susie LeBlanc and Jeff Aubrey. So I'll turn it over to you.
Thank you very much. It's quite vast. I mean, brain imaging guidance, targeting, and monitoring for both thermal applications, BBB opening, neuromodulation, histotripsy, you name it. We had a pre-meeting. Can we have the slides on, please? Yeah. Way before. Okay. Sounds great. So basically, we tried to add some topics out of this wide range of discussion possibilities, and we would like to address the limitations of current treatment planning models for both thermal applications, neuromodulation, and BBB opening, but mostly for the first, for the limitations, mostly discuss about thermal treatments. Also, we highlighted burning questions about target engagement in neuromodulation. The safety margins. What are the safety margins for all those applications, and how could we expand the safety margins? And finally, the shortcomings of existing algorithms for BBB opening, and again, how to improve those. And concerning the limitations of current planning models that are currently being used, again, mostly for thermal applications, but also for other applications. Recently, there's been an interesting paper benchmarking different approach to model the propagation of the beams. And we actually compared 12 different models that are currently being used. This is just the first step, just making sure that different groups around the world using different models and different simulations would all agree to the same results on very simple, I would say, skull models. But the thing is, this is just to make sure that they all give the same results. But then, how are they sufficient sufficiently accurate for all the transcranial applications, and mostly not only being able to predict the phase and the dephasing induced by the skull, but also intensities at focus. So those are things that we're going to discuss all together. Can we also enhance and go one step beyond, and not only try to predict the temperature elevation, for example, for one single sonication, but how this is going to evolve in time from one sonication to another one, and take into account, for example, tissue changes? Concerning target engagement in neuromodulation, it's very specific to neuromodulation. Currently, we have lots of imaging readouts for other modalities. For thermal ablation, for example, we are lucky enough to have access to thermal images with MRI. We can also use some estimates based on ultrasound imaging, but mostly MR mapping is quite accurate and currently being used a lot. For BBB opening, again, thanks to gadolinium leakage with MRI, we can assess the efficiency of BBB opening, or we can use also radio tracers by using SPECT or TEP. But how would we confirm target engagement and target and safety use in neuromodulation? That's a big question that we try to answer. And for example, what kind of imaging modalities can we use to guide the treatment for neuromodulation and ensure target engagement? MR-RFI is one way to at least locate the beam. Also, of course, functional MRI, but there's also extensive work currently on functional ultrasound imaging, so we can discuss how this could be integrated. And also discuss if there's a role use animal models, to continue to work on animal models to show target engagement and find some readouts from the models, from those animal models, or should we continue directly research on human populations and look for feedback from the healthy volunteers or patients? Now, concerning BBB opening, I will leave it to Susie to introduce this.
Hi, I wanted him to save the blood-brain barrier opening for me. As a neuroradiologist, this is a particular passion for me. And the last two questions from the prior session really highlighted the importance of needing to adequately monitor and gauge the success of blood-brain barrier opening. So as you see from the slide here, we have ways of confirming that the blood-brain barrier is open, but how can we make sure that it's consistently open in a safe manner? And I also want to think of the blood-brain barrier not as an on or off switch like the light switch, but kind of like a dimmer. And there was an interesting presentation that's pre-recorded that you can see online, BRT18, and it was discussing the blood-brain barrier phenotype with different types of microbubbles and ultrasound frequency. And I highly recommend that you go and listen to that presentation, and I'm sure we'll talk about it a little bit here. But again, we may want to get to the point where not only can we just open or close the blood-brain barrier, but can we do it in different gradations for smaller, larger molecules, larger CAR T cells. So this is also going to be an area of great interest. So here are some of the burning questions we're going to get to, but for now I'd like to let all of the panelists spend 1 or 2 minutes introducing themselves. So first, why don't we hear from Dr. Krishna?
Thank you, Dr. LeBlanc. I'm Vibhor Krishna. I'm an associate professor of neurosurgery at UNC. We are involved in clinical treatments using focused ultrasound for patients with essential tremor and Parkinson's disease. And during those treatments, we interface quite a bit with the challenges around accurate and precise planning for patients for thermal ablations, and how to obtain precise intraoperative feedback for thermal ablation. As we know that thermography images have shifts that create errors in localization, and so how do we overcome those challenges and use multimodality assessment of lesions? That's another area that we are focusing. And then finally, imaging the lesions in long term, as you know that in majority of patients, the lesions are not appreciable in delayed imaging. And so another area of active investigation for us is to use diffusion MRI to image delayed lesions and understand what lesion characteristics are associated with good long-term success.
Okay, thank you. So we look forward to hearing your thoughts soon. We have in person Dr. Liu.
Thank you. Thank you for inviting me to the panel. And I personally, as a double-in engineer, and my expertise actually is in the medical device system design. But I'm very lucky to join the Taiwan neurosurgeon team to, right now we kick off some clinical trials, use the ultrasound phase array system. And about 10 years ago, we started looking at the potential of the neural navigation to guide focused ultrasound. But at the time we proposed this concept, actually many people is not like it because we are exactly lacking the topic today we are talking about. People are thinking neural navigation without any guidance and monitoring and targeting. How can it become a usable tool to guide the focused ultrasound procedure? So I think maybe that's why I'm being invited in this panel. Thank you.
Yep, great, thank you. Let's hop back to virtual, and Dr. Verhagen, can you introduce yourself?
Hi, Susie. Thanks for the invitation. I'm sorry I cannot be there in person for prior obligations. But I'm Leonard Verhagen from the Donders Institute at Radboud University in Nijmegen, the Netherlands. And I'm an integrative neuroscientist, having worked both in non-human primates and human neuromodulation and neuroimaging. And within the domain of focused ultrasound, my expertise lies squarely in neuromodulation. And I chair iTrust, the International Expert Group on Transcranial Ultrasonic Stimulation. And within that context, I'm usually the person to remind everybody that neuromodulation means planning and targeting not only in three-dimensional anatomical space, but also considering the intensity there as one of the main drivers for those. But for neuromodulation, it also means considering the high-dimensional brain state space, where efficacy of fast neuromodulation is also dependent on neurophysiology, neuroactivity, neuroanatomy. And actually, we need to target many more dimensions in space and time to do so. I'm looking forward to the discussions here.
Great, thank you. And last but not least, Dr. McDonald.
Thank you for the invitation. I'm Nathan McDonald. I'm a physicist and a professor of radiology at Brigham and Women's Hospital. I've been working with focused ultrasound for a very long time. Initially, my work was largely related to MRI-based methods to monitor thermal therapies and other MR techniques for monitoring ultrasound therapies. And as our therapy started moving more and more towards bubbles, we got more and more involved in using acoustic measures to monitor and control these bubble-based therapies, and a little bit into the, going to imaging for that. So yeah, those are my main areas of interest. We do both have a clinical program and we work in preclinical models as well.
Great, great. And I'd like to stress to the audience how important this topic is. It's actually permeated through so many of our different sessions on our different subtopics. How do we confirm the target engagement? How do we monitor these treatments? And I heard this morning at the FDA meeting where they met with 8 focused ultrasound companies that this is a critical area. The FDA wants to know this data before they go about approving or looking at studies that are going to be approved. So really, really important topic, and I look forward to the discussion, and Dr. Aubry is going to get us started.
So, by the way, so I'm Jeff Aubry, and I'm a physicist. I'm a research director at Physics for Medicine Paris, and I'm interested in all applications of focused ultrasound in the brain, as long as this is done non-invisively and transcranially. So we're going to go through those questions that you can see on the screen. Of course, if you have any burning questions, come and ask your question, and we will just stop and address your question first. So the first one was about the limitations of current treatment planning models, especially for thermal ablation, but not only. And one of the burning questions was, are they sufficiently accurate for transcranial applications? Maybe I can say a few words about that. So basically, I would say there are two things. One is to, during the planning process, one is to compensate for the aberration corrections. So far, many models have been developed and being quite successful to compensate the aberration. So I would think that currently the tools that are available are precise enough to achieve accurate transcranial focusing. Now the next stage is to predict the intensities at focus to help further plan the treatments. I would say that we're getting close, and some teams are more or less advanced in estimating this. I guess all the models, among those 12 models that have been compared recently, they can all achieve an estimate of the intensity. Now, how accurate is it, and what is the error is what needs now to be optimized. But it's clearly on its way, and there is a strong need now to actually validate against measurements. And when I mean measurements through skulls, not only one skull, that's what we see most of the time, just a validation on one skull. You need actually to repeat and have, I don't know how many, but quite a few skulls because of the variability between subjects. So it's very important not to optimize the simulation on one skull. We talked about machine learning before, and even if you are not using machine learning, but one of the models, the 12 models that that were compared in the recent paper. It needs to be validated on a wide range of scores. And so I encourage you to look at BRT 21 and 27 here during this meeting, where they actually did some comparison on some scores. Again, it's a first step. It's great. You see on those papers, but currently the number of scores on which they validated their approach is still limited. So there is much more work to do on this. I don't know if anyone might want to comment. Maybe Nathan?
Yeah, I have a comment. I think that the huge amount of data that we're obtaining during our these essential tremor treatments is the best opportunity we have to validate these models. I mean, the resolution is low, the time resolution is low, and we're comparing temperature instead of the direct pressures. But this is in vivo data in humans, and just going back through the cases we've done, we know that that things vary by orders of magnitude between patients. So that we've been trying to mine the data that we've been acquiring during tremor cases, and I think that's a really good opportunity, not just for thermal ablation, but to really validate these models to show regulatory agencies that we can do it accurately. It's going to be very important for neuromodulation or doing blood-brain barrier opening, outside of an MR environment and that sort of thing.
Maybe one thing I want to add is the computational effort. Right now, probably another things we need to concern, because in my personal experience, that if you want to simulate the whole pressure field, that takes time, especially for the inhomogeneous medium. And that probably, because in my personal experience, that takes a long time to calculate. And the real-time calculation and do the treatment planning real-time actually is quite important. So I want to echo the Rick's former sections that probably AI and machine learning probably can play a very important role to help us to cut down a lot of time to calculate the pressure.
Yeah, I fully agree. And on top of that, not only novel techniques like machine learning, but also if you look at the computers, I mean, the computer industry, how the power of the computer increased as a function of time, using almost the same, I would say, modeling in our lab. It took a week 20 years ago to model the propagation of the wave through the skull. And then we went down to a day that was 15 years ago, and then to a few minutes, and now we require only a few seconds to at least do one propagation. So we benefit a lot from all the progress on the industry side, not only the methods, but also the computers themselves. And to transition to the next question, actually, so this is for you, Nathan, you have all those data, not only for the first sonication, but also how it varies from sonication to sonication. Maybe Vibor, could you elaborate a little bit more on the effect that you see when you increase the power, and how different it can be between the variability in the target coverage that you see between what you plan and what you actually see on patients?
Thank you, Frank. That's a great point. And during treatments, we certainly have noticed, and others have reported this too, that sometimes you could see smearing of the focus in directions that we didn't anticipate before, as we are increasing power during subsequent sonications. And the whole idea that a volume of tissue that we want to prescribe a specific treatment to, and actually what we get at the end, there is some heterogeneity in that. And when we add the shifts in thermography images, it becomes challenging to accurately localize those back to the prescribed volume. And so the challenge that we face is first of all to make sure that there are no off-target areas that are heating. All of us who have done these cases know that once in a while you would have cases where there are spots that are outside of your treatment window that could have heating as well. And so to your point, if there are ways for us to simulate this and anticipate some of these off-target areas that have high temperatures, would be quite useful and improve patient safety. And then second point would be that as we intend to increase the target coverage with subsequent sonications, how do we make that process a little bit more reliable, where the discrepancy between the intended volume and the actual volume of delivery, their shape and sort of three-dimensional shape is conforming to the target itself. And so that's another area that clinically we face. And finally, we all of us notice that as we go towards the ablative ranges and increase the power, skull heating shifts the thermal spot in interesting ways. The Stanford group presented some of their data a few years ago where the focal spot shifted in different directions. And so how do we make this more reliable, compensate for these, anticipate and compensate for some of these changes, and keep the therapeutic area or therapeutic volume in play during the whole treatment? These are the challenges that we face.
Thank you for those comments. I'd like to discuss a little bit how, while Vibor, you use continued thermal rise to get to your thermal heating. Jean-Francois, you tend to think that perhaps neuromodulation as a test run for engagement may be possible in a situation like this to avoid the need to better understand repeat thermal exposures. Maybe you can put your 2 cents in here.
Yeah, well, so I would say my response would be very different today from what I would say a year or 2 ago.
Okay, do tell.
Because it's so far, it was important to perform mild temperature elevation in order to check the positioning of the focusing. Now we're having more evidence that neuromodulation can actually achieve strong target engagement, at least strong response from the patient. So I'm talking about essential tremor patients, and I encourage you to look at the video that we uploaded at this meeting to suppress tremor during the treatment with very low power. So it means that now I'm convinced that one could use neurostimulation to check the efficiency of the targeting and the tissue response. Now the next step is to discuss with neurosurgeon and would they agree to ablate a region that is not exactly what they were planning to treat, slightly off. We're talking about 1 millimeter off. So it's just that at least on the neuromodulation side, we can prove that this target was more efficient. But the thing is, do you want to ablate this? Are we going to change the way we treat the patient? So in our case, for example, we showed that by switching from the VIM to the DRT fibers, in the DRT tracks, it was more efficient to suppress the tumor. But yet, the decision of our neurosurgeon was to stick to the VIM to perform the treatment. So I would say it's too early to say what role it will play, but clearly it would be a way to try to decrease the number of thermal sonications that are needed to guide the treatment before switching to full power and ablate tissues.
Vibor, I'm going to wait for your response to that in a minute, but we have a question from the audience.
Thanks very much. I had a question going back to the modeling a bit, taking advantage of the expertise on this panel. So one of the big things in terms of getting accurate models of the brain treatments is obviously the acoustic parameters that you assume based on the CT data. And as you know, there's a sort of a wide variability in terms of parameters that people have reported different groups. And I guess maybe part of that has to do with the models that were used to determine those parameters. And I'm just wondering if you could comment on how to sort of, how we can reduce that variability and what sort of parameters are best for a given model.
For neuromodulation, you mean? Or
Pardon?
The acoustic models of transcranial, yeah. We're looking to see if we can improve them. And then, the efforts that I did before were trying to use simulations and comparing it to the, temperature rise to find the best relationship that, predicts the heating that we have during the tremor cases. And I've been working on expanding that to not just looking at one point in space, but trying to, optimize, find the optimal parameters that best match the shape of the heating as well. Jean-Francois has done a lot of the comparisons of the different models. You can comment on that.
Yes, well, it's not first. So this comparison was led by Triby, but so Brad led this comparison, and it was more. So each of them would use similar parameters, and those were more on skull models. So it was kind of a homogeneous skull, just to compare the efficiency of each of those simulations. Now, switching to reality and to real skulls, I would say. So this would be the next step. They are continuing to work on comparing those simulations on experimental data. It's important, I think, that almost each individual model might have to optimize the parameters. It's difficult to take the parameters from one model and compare to another one. We used, for example, your parameters on experimental data that we had from Insightec. But the thing is, so there was slight differences between your model and our, not so much. But I could not tell. Of course, you might have better results with your simulation. You optimized your parameters with your simulation based on a given set of parameters. I mean, the resolution of the CT scan that you used is important. The resolution of the simulation that you use. So if you change one of those parameters, if you change the resolution, you might have to change also the modeling of the skull. It would not be exactly the same. So the maximum speed of sound, for example, would not be exactly the same. So be careful. There's lots of current validation of models that compare to experiments, but so it's just a starting point for you to have a rough estimate of the maximum speed of sound, minimum speed of sound, same thing for density, but then you would have to adjust for your own model base. And once you do so this would be maybe for the FDA or for companies who wish to translate to a final product. At some point, you'll have just to stop adjusting, and you will have to use the exact same model for all the simulations.
And I think another issue that should be brought up is this second question here. And in my mind, one of the biggest things that we could do to improve, thermal ablation in the brain is to really understand why, as we go along the treatment, it becomes harder and harder to reach peak temperatures. And if it's something that's changing in the skull, maybe we can change our model and restore the focus back. Because if you compare the rate of heating at the beginning of the treatment to the end of the treatment, one look I did, it was like it dropped by like 40%. And if you could imagine that we could, stop excluding some patients, we could maybe expand the treatment envelope. So I think that's like one area that's really key that really would help a lot. Maybe we can't correct for it, but.
I was about to add something, but we could talk for hours about that. So I guess we should maybe switch to the next topic and maybe have Lennart more involved in the discussion now, talking about target engagement in neuromodulation. So what do you believe is best to get some readout of the target engagement, either imaging or other modalities to do some recordings on the patients or the volunteers?
So I would also like to distinguish between target verification and target engagement. And I'm not entirely sure if we have really established models for the target engagement, but I'm hoping we might be getting closer to the verification in the first place. So what I mean with that is we would like to have an idea of our physical exposure of the energy we've delivered at our target to know that the targeting might be accurate at the physical level. But then the next level means how the physical intervention interacts with the neurophysiology and what kind of effects it has. And you often see major differences between the physical and the neurophysiological domain. If we think about electromagnetic stimulation, we might have physical models, and think about transcranial magnetic stimulation, that our field is a few centimeters large or larger still, yet our functional resolution can be up to like half a centimeter, nearly an order of magnitude different. And that's because of we're interacting, and the result of our stimulation is an effect of the interaction between the physics and the physiology. And Jean-Francois, I was so happy you referred to some of the work you presented yourself on targeting the DRT. And here, in the case of essential tremor, we have a very clear clinical and clinically relevant readout. And maybe our best proof of target engagement is that physiological and behavioral effect, that the tremor is reduced, and that's the ultimate goal. But we generally do not have that available for many other clinical trials. Consider, for example, psychiatric indications, where you don't have an immediate consequence, an immediate effect. And then we would like to establish new approaches for target engagement to show that our exposure was indeed an effective dose and that it led to a true neuromodulation. And many of us are considering that might mean a neuroimaging approach. For example, using MRI, where we're using bold imaging to see if we can observe a modulation, or in the future, hopefully even imaging of blood flow, for example, using functional ultrasound imaging. But the critical question still remains, in what do we expect? Do we even expect a bold rise or a bold effect immediately after ultrasound sonication? Or are we actually expecting a disruption of bold activation and looking at reduced bold effects? And these are not mapped out. In fact, what we already know is we will probably expect different effects depending on whether you have an active tremor or whether you are at rest, whether the circuit you're targeting is engaged or not, and again, depending on the brain region we're stimulating. This is a complicated matter, and I'm looking forward to diving deeper into it, but I'm always also skeptical of extrapolating what we find in one indication and in one brain region to many other indications and many other brain regions. So this is probably a concerted effort that requires many different labs joining in.
And how, what about the difference between animal models and human populations? For example, you mentioned the accelerators for essential tremor. We could not do that on animals. So what could we benefit from animal experiments as opposed to human experiments concerning the target engagement or verification?
So one of the, well, first let me comment that in the questions we have an or, animal models or human populations. And that already, I think, is slightly misplaced. To me, it's obvious we should pursue those tracks in parallel. We should not delay clinical trials in humans. This is current and available now. And again, the tremor and with accelerometers are a fantastic example. But let me take another example. For certain clinical indications, we would like to know if we're mostly recruiting excitatory circuits or inhibitory neurons. And these measurements are currently not available in humans, at least not in a wide range that truly allows accelerated research and a fast pickup. So here, the fastest way to clinical impact is actually using animal models where you can directly measure and isolate excitatory and inhibitory circuits and look at the specific effects of your ultrasound protocols on the balance between excitatory and inhibitory engagement. And that will inform the type of protocols that we then need to test in human populations. If we would do that in human populations alone, it will be a very long iterative process of trial and error before we've actually optimized our parameters and our estimations. So that's why I would argue this needs to happen in parallel and closely informed.
Thank you. As I don't want us to run out of time and need some time for the other questions, I'm going to elude almost the safety discussion that we were planning to have, mostly about neuromodulation, and refer to current work within the iTrust consortium. So stay tuned. There will be an expert consensus soon that will be released by the iTrust consortium, discussing, what are the recommendations for safe neuromodulation parameters. And I would like to spend a little bit more time on the shortcomings for BBB opening, and maybe ask Nathan and Hawley to discuss a little bit about what can be done, what should be done to improve the BBB monitoring. Before we have a question from the audience.
So actually, this is a good segue because you almost just touched on my question in the previous comments. But I feel like clinically there's just an armamentarium of like imaging and other readouts that are missing from a lot of preclinical studies. And so is there a benefit, which I think that there is from what was just said, to adopting more clinically relevant technologies and techniques within preclinical studies? Or do things like changes in the anatomy, whether you're in a human versus mouse versus rat versus pig, whatever, and even changes in technology kind of obviate like the need for the symmetry between clinical and preclinical? And then on top of that, how do you reconcile the differences between anatomy and technology to better inform the clinical translation?
Well, I can speak just from my experience in the most recent years has been for blood-brain barrier opening. And we know that the BBB opening is very dependent on the ultrasound frequency. And people want to work with mice and rats, but if we're using the frequencies that we want to use in humans, which are much lower, then you run into problems. And that you can scale up to larger animal models, but sometimes it's just not possible, and there's no disease models. So yeah, that can be an issue, and we could, it's very hard, sometimes just from the size, and I'm not even going into like the neuromodulation and the differences in animals and anesthetized animals and different anesthesias versus alert animals versus humans. There obviously going to be differences, but yeah, I think it is important, to have all of this data that we can get during the experiments if it's possible. But sometimes just the money is, I'm not going to do an MR-guided experiment just because it's expensive,
Yeah. Thank you.
Okay, so we're going back to the BBB opening because I want to hear more from the panelists about the shortcomings of the existing algorithms that we use, and what are you doing, and what research, or using an MRI-guided system or an ultrasound-guided system, are you looking forward to improving the ability to engage and monitor the blood-brain barrier opening?
Why don't you go ahead and start?
Yeah, about to use the neural navigation. I think most people are thinking about there's certain lack of use neural navigation guidance. So in my whole pictures, right now the neural navigation is a incomplete version to use that because we are lacking of the feedback. So how do we compensate those incomplete things? I think first I will suggest to use some acoustic feedback to compensate those shortcomings. So that's why we are building a phase array version of the transducer. So I think the niche of the phase array can do first is the phase correction of when you transcranially sonicate the brain. And secondly, maybe I think another form of the ultrasound is to receive. We probably can borrow the ultrasound imaging niches to receive those signals, not only to do the PCD. I think we have a greater hope to use this kind of signals to reconstruct some focal beam mapping. I think this should be a goal in the future.
I think our experience, we worked for years in animals, and then we did a clinical trial, and it was pretty quickly we realized that a lot of the work we've done in animals was not very predictive of what we're doing in our patients. So we're working with, in this GBM trial, and we're treating the infiltration, and that infiltration of GBM is going to be largely in white matter. And in our small animal experiments, small animals don't have a lot of white matter, so we don't have a lot of experience there. And when we were, do animals, we give very high doses of microbubbles that we're not allowed yet to give in our humans. So instead of using these high bubble doses, we're using infusions over lower doses, and so that's very different. And we developed these nice tools to control and monitor the procedure. But when we go to the humans, we have this big skull in the way, and that becomes more of a challenge. So just going to this first trial that we were involved with really had us take a step back and revisit going back to preclinical models to try to understand better how we can do it in a more realistic situation. So I think there is a great need for monitoring and for treatment planning. So I think if we're going to use the bubble signals to control the treatment, we need to have an idea of how many bubbles there are at your target. So we need to get some sort of pre-treatment imaging. Maybe it's just segmenting white matter, gray matter, or maybe doing some sort of perfusion imaging before treatment and integrating that into our controls if we want to use these signals to control or to understand, what thresholds are. If there's no bubbles there, you're not going to see a signal, and you don't know if that's because the skull is attenuating you or you don't have enough power in, or if there's no bubbles.
Yeah, I especially like your point about imaging and monitoring white matter versus gray matter and being able to predict if you need different concentrations of microbubbles or energies and how to switch from one to the other within a treatment volume. Can you talk about your experience with that so far, or are you looking at it?
Well, I've been trying to go back and analyze the data, but it's very challenging. We've been doing these treatments where we have all of these overlapping spots, and I'm trying to relate what we measure at each spot to the outcome, and then now I'm trying to go in and simulate it and look at what the tissue is. But I don't know if it's going to be that successful, but this is the kind of thing we need to do, and probably need to take a step back and do it in animals.
I have a question.
Yeah, this is Andreas Melzer from Dundee and Leipzig. I have a question to the panel for all the targeting. How about ARFI? When could it be done? Is it also possible in low-intensity focused ultrasound procedures, or is the energy too high needed? So what's your view, and what could happen in the future with ARFI?
I'm not sure if, the main application that I would think it would be perfect for might be neuromodulation, just because we can't do the thermometry there, and we don't necessarily have any other feedback. But I'm not sure that you can do ARFI. If the exposure levels you need for ARFI are going to actually be higher than what you're doing for neuromodulation, and if that might be a problem. For BBB opening, we do have some feedback, and the precision may be not as critical for the applications we're working with right now. So having a verification of targeting may be less important. Obviously, we want to know, but you could probably use ARFI in that context too. But again, you may need higher intensities than what you want to use for the treatment itself.
I think it's always interesting when panelists have different points of view, but I completely agree with you, actually. I second what you say. It's true. On principle, yes, we should be able to use MR-ARFI with low intensities, but the thing is we don't have the sensitivity to do so. So from our experience as well, when we used both the neuromodulation sequence and MR-ARFI, actually the level of energy we had to use to see something on MR was much higher than what was needed to achieve neuromodulation. but maybe with more sensitive MR sequences, it might be possible. We've tried for almost 10 years to try to increase the sensitivity or have faster acquisition so that we could average. But at least in our group, we made some progress. We are not there yet.
So we only have a few minutes left, so perhaps we can go to the panelists and just ask for your last-minute thoughts on where you think the greatest unmet need is that you encourage researchers in the audience to try to think about and answer some questions. So Lennart, you want to tell us your hope?
Oh, I'm actually very hopeful, and this symposium has already shown the real strong potential, also the strong clinical potential for these. So yes, I'm also very hopeful actually about MR-RFI. We've started working on this, and there's a lot of opportunity to improve the physical verification of targets, both with ultrasound imaging, as we've heard, and I also think MR has a role. And then I'm very much looking forward to using MR imaging for verification of neural engagement. And this is in the early days, but I'm excited, and that will bring us a big step closer.
Okay, Dr. Liu?
Yeah, my hope is the same with the Lennart. Talked about the use of full ultrasound imaging. They can do something about our future system. Yeah.
Okay. Nathan?
I think for thermal ablation, as I mentioned, the issue of the skull, and it's something we haven't discussed, but having 3D temperature mapping would be very important to avoid side effects. And for the BBB opening, I think having a better understanding of what the bubble population is and improving our treatment planning based on that, I think is the biggest unmet need in my view.
Jean-Francois?
So I would say what is amazing is that the needs for imaging guidance and targeting are so different between histotripsy, BBB opening, thermal lesioning, and neuromodulation, and yet for each of those indications so far, we've been able to offer solutions to that. So maybe there's also strong potential in kind of combining all the solutions that have been applied so far to each of these individual indications. And it's great to see all those applications currently translating into clinics. It's been a long path for some of those. I mean, thermal therapies were very fast to translate to clinics. Neuromodulation took a long time to do so, and we are still actually working on it, but it's very promising.
I think as a clinician who's performed focused ultrasound procedures, in order to engage more people to have the confidence to do these procedures, this topic is so important. I want to have confidence from the modeling. I want to have confidence that my readout is going to be there. I want to have confidence that I can monitor it during the treatment. So I think as we try to engage more clinicians, neurologists, neurosurgeons, other surgeons doing this everywhere in the body, I think we really need to hone down on this topic and improve it so that streamline to the clinic can be much easier. Vibor, last minute thoughts?
Thank you. Yeah, so I'm very excited about, as a clinician, as a end user of this, and very excited to see the developments. Very excited to use neuromodulation to optimize our treatments. And one thing that we want to, as clinicians, want to take into account is not just the efficacy, we are also chasing safety here. And so creating these paradigms that are very efficiently, we are able to sample the desired area of the tissue to be able to make decisions about efficacy, but also safety. And so these are some thoughts I have.
Okay, I'm going to put you on the spot as we finish the session. With respect to neuromodulation for target engagement versus thermometry, which would you use? Versus tractography for your treatments?
So absolutely, if there is a way that Frank can show me that this area is more efficient and safe, then that's where we would go, right? This is what we do in deep brain stimulation all the time.
Okay. Any last minute thoughts?
No.
No. Well, thank you all for attending the session. I hope it was informative, engaging, and inspiring you all to do some research and move forwards with this topic. Thank you to the panelists for joining and to Jean-Francois for moderating.
Okay, everyone, so now we're about to break for lunch, and then join us here after lunch at 1:35 for a panel session on gynecologic indications. And I would just want to remind you that in addition to the lunch next door, downstairs, we, all of you are welcome to join a special Women in Focus Ultrasound luncheon. This is in the Brookside A and B rooms downstairs. Food will be available outside the room. Please join with other meeting participants who are interested in the advancement of women in the focus ultrasound field. And this will be a forum to socialize and network, discuss challenges and issues, and identify opportunities for the foundation to help. And the program will include a brief panel discussion with Alyssa Kanafagu, Hong Chen, and Natasha Shabani, and myself, and open conversation. And a big thanks to Bracco, who's the sponsor for this luncheon session. And they've also provided a short video highlighting the importance of this topic that I believe we'll share now as we head to lunch.
La scienza ci dà dei superpoteri perché riesce a portarci in territori inesplorati, anche fuori dalla nostra zona di conforto, e l'impossibile lì può diventare reale. Parlo della fisica che è la mia materia, la materia che io ho studiato. La fisica in qualche modo ci obbliga appunto a abbandonare tutto ciò che conosciamo e succedono delle cose straordinarie. Per esempio il tempo sente la gravità, così come una mela viene tirata giù dalla gravità, il tempo rallenta con la presenza di una massa. E poi il superpotere, la consapevolezza dei superpoteri anche quotidiani. Guardare lontano in distanza significa anche guardare indietro nel tempo, perché la velocità della luce è illimitata. Quindi ogni sera che guardiamo un cielo stellato, ognuno di quei puntini è un momento di passato diverso. La matematica ha bisogno di essere inclusiva perché la matematica è comunque la condizione, un abilitatore di futuro, è un linguaggio, è il linguaggio del nostro universo, e così come mettiamo tanto sforzo nell'apprendere l'italiano perché siamo cittadini di questo paese, nell'apprendere l'inglese perché siamo cittadini del mondo, la stessa esigenza di comprensione dovremmo anche trasferirla sulla matematica. Non possiamo rimanere fuori dal linguaggio di ciò che ci circonda ed è anche appunto un abilitatore di futuro perché è il linguaggio delle STEM, è il linguaggio che ci permette anche di avere uno spirito critico, di uno sguardo sul mondo, indipendentemente dalle scelte di carriera che uno fa, che ci rende più consapevoli e anche più in grado di non essere manipolabili e di avere un senso critico forte sulle cose che ci circondano e anche una mente più aperta. Le ragazze devono pretendere di non restare fuori dalla matematica perché la matematica è una condizione necessaria perché si possano avere nel futuro pari opportunità. Il vero cambiamento avverrà quando ci sarà un numero sufficiente, uguale, superiore di donne nelle materie STEM, perché sono questi luoghi dove si immagina e si rende possibile, si abilita il futuro. Non essere presenti in questi spazi significa comunque non far parte del mondo che verrà. L'attività di Fondazione Bracco è un'attività importantissima perché stimola, incoraggia la vocazione scientifica nelle ragazze, lavorando anche su tutti gli aspetti che influenzano questa vocazione, ed è quindi un lavoro essenziale proprio nelle preparazioni di un futuro che tutti possono partecipare in modo uguale ed in modo giusto.